Good morning, everyone, and thank you so much for joining me this early in the morning. My name is Richard Cheng, and I'm one of the heart failure and heart transplant cardiologists here at the Regional Heart Center. I have the privilege of giving you this talk on the topic of cardio-oncology this morning. What really motivated us to be involved in this topic is we all see these patients frequently in clinic who come in essentially with various types of cancer. They get treated, their cancer gets cured, however, they go on to develop significant cardiac disease. So because of this, myself and my colleagues, in collaboration with the SSCA, have formed a cardio-oncology clinic, and I want to give you some of the highlights on this topic through today's course. So through this talk, we will define the risk of cardiovascular complications in cancer survivors. I want to evaluate the role of cardiac imaging and biomarkers and how this can help you risk stratify your patients and how you can use this to help you manage your patients. I want to provide you a framework on how to treat cardiotoxicity, not only from a treatment standpoint once they have LV dysfunction, but also in terms of how to prevent cardiac toxicity. We will also explore the need for cardio-oncology as a discipline and how this differs from standard cardiology. So let's start by looking at a case. So this was actually based off a real patient I saw in clinic, and I'm sure many of us have seen patients like this. So Mary is a 40-year-old woman. She has no past medical history. She's led a normal life. She's been very active. She completed college, has been working on a regular basis, and has children at home, doing yoga on a consistent basis with no problems. However, one day she noticed a lump on self-breast examination on the left side. She sees her primary medical doctor, you for example, and she undergoes a breast exam in clinic, and a mass is confirmed over the left breast. Because of this, she's referred to the SSCA, where she's diagnosed with early stage left-sided breast cancer. So after biopsy confirmation, she eventually undergoes a lumpectomy, radiation therapy. She undergoes ACT, which is doxorubicin, cyclophosphamide, and paclitaxel as adjuvant chemotherapy. She receives a total dose of 240 milligrams per meter squared of doxorubicin. Her biomarker is HER2 positive, and she started on trastuzumab about 1 month after she starts the doxorubicin. With this treatment, good news, her breast cancer is in remission. She's happy, she feels great, she goes back to doing her regular activities, and she sees you on a consistent basis, doesn't have any problems. However, several months later, she comes into clinic complaining that she's now short of breath. She finds that when she walks her dog, she has trouble climbing up the hill. She has trouble sleeping because she wakes up short of breath. I want you to think for a minute here before we move on. What is her risk of cardiotoxicity from what has happened? And the other question is, what can we do to decrease her risk of this happening? So take a couple seconds to think about this. All right, so let's start by going over the epidemiology. I want to talk a little bit about the background because I think this is very important to put this into context in terms of what we're dealing with. So this is data based from the American Heart Association as well as the American Cancer Society. As many of you know, in the United States, prior to age 74, the leading cause of death is cancer. The lifetime risk of cancer is pretty high. It's 43% in men and 38% in women. In men, the most common cancer is prostate cancer. In women, the most common cause of cancer is breast cancer. However, this paradigm shifts after age 74 years. The leading cause of death in the United States is cardiovascular disease. So based on this, as you can see, there's a huge burden of disease from both the cancer as well as the cardiovascular perspectives. And just like when you go grocery shopping, you wouldn't want to leave one bag of groceries behind. Here, you don't want to ignore one of these syndromes. You really want to treat both of them and pay attention to both of them. I'm going to show you how these also interact closely in the following slides. So cancer is really the tip of the iceberg. Our oncologists have done a really great job in treating patients with various types of cancer. In 2008, there were 11.9 million survivors of cancer in the United States. This is a great thing. I mean, in the past, a lot of these patients would have died. However, the problem becomes as more and more patients survive, a lot of them go on to develop cardiac disease. If you look at overall survival, in 1975, it was about 50%, so half of patients survived. In 2007, 67% of patients now survive cancer. So there's this huge increase in survival, which again is a great thing, but you have to treat these patients long term. If you look specifically at early stage breast cancer, based on the SEER data, which is a database of cancer patients, there's a 98% 5-year survival. So these patients do very well. Our oncology colleagues have it figured out. On the other hand, I'll have to show you how we deal with this from a cardiology perspective, because now we have all these patients that we have to worry about that have been exposed to anthracyclines or trastuzumab. So this is data looking at childhood cancer survivors. So this is all types of cancer, but essentially patients who got treated in childhood, and looking at what happens to them after age 35 in terms of secondary malignancies as well as cardiovascular events on the right. So on the x-axis, we have age in years. On the y-axis, we have cumulative incidence. In terms of neomalignancy, if you compare survivors of childhood cancer compared to their age and risk matched siblings, what you see is the incidence of secondary malignancy is much higher compared to their sibling. How about cardiovascular events? Similarly, the risk of cardiovascular events in a survivor compared to a sibling is extremely high. Looking at this from a hazard ratio perspective, so again, these are survivors of childhood cancer. In this case, 1 is neutral. Anything to the right of 1 means that your risk is higher. To the left of 1, your risk is lower. If you cross 1, it's not significant. So for many of these conditions, what you see is there's a trend towards increased risk, but this is not significant. If you look at cardiovascular risk, clearly, the risk of all these cardiovascular events is much higher in survivors of childhood cancer compared to their siblings, including stroke, which confers a 6.7-fold risk, myocardial infarction with a 5-fold risk, and heart failure with an 11-fold risk. So this is for all survivors of childhood cancer. So let's put this into perspective. What does this mean? How much does this actually occur? To give you an idea, if you look at pediatrics who are exposed to anthracyclines or radiotherapy, so these are really the highest risk patients. They have a 15-fold increase lifetime risk for heart failure compared to general population. So much, much higher. You have to follow these patients very closely. If you look at adult survivors of aggressive non-Hodgkin's lymphoma, they have a 17% incidence of clinical heart failure at 5 years. So about 1 in 5 risk of heart failure at 5 years. In the general population, we should quote them a 1 in 5 lifetime risk. So as you can imagine, this risk is much higher. For adult survivors who have been exposed to anthracyclines, there's about a 1 in 10 overall incidence of heart failure at 5 years. So again, much higher than the general population, and 98% of these cases occur within the first year of being exposed to anthracyclines. So let's move on and talk a little bit about specifically the breast cancer population, because we all see many of these patients in our clinics. So this was data from the SEER database again, of 63,000 women age greater than 65 with breast cancer. On the x-axis, we have time in years. On the y-axis, we have their proportional cumulative risk of death. So in other words, what's the most common cause of death at a certain time point? So for these women diagnosed with breast cancer, from the time of diagnosis, early on, the leading cause of death, as you would imagine, is going to be breast cancer, as shown here. They also are at risk for other cancers. Over time, the risk of death from breast cancer decreases dramatically. The risk of secondary malignancies stays about stable. What about cardiovascular risk? How does this intersect with our risk of death from cancer? So it's shown here where early on, the risk is somewhere in the 25% range. However, over time, this increases about 8 years. The risk of dying from cardiovascular disease actually is higher than the risk of dying from breast cancer. Keep in mind that these are actually patients with breast cancer. So I think this puts, again, into perspective how high the risk of cardiovascular disease is in these patients and why we really have to focus on this as a discipline. So you might wonder, how do we get cardiotoxicity from these chemotherapy regimens? This is a very complex diagram, but take-home point is really it can hit all aspects of the cardiovascular system. In most cases, when we talk about cardiotoxicity, what we're referring to is really heart failure, because we mean cardiotoxic to the myocytes. These cells die. A lot of agents can cause this. We worry most about anthracyclines and HER2 blockers, but also proteasome inhibitors, alkylating agents, tyrosine kinase inhibitors, VEGF inhibitors can all cause cardiotoxicity. As you can see, these other agents here can cause other effects, including ischemia, valvular heart disease, pericardial disease, and arrhythmias. These are all significant and things we need to watch for, but I'm going to focus mostly on cardiotoxicity in the sense of heart failure because this is what we see the most, and this is the best studied of these different side effects of these chemotherapies. You might ask, what about radiation therapy? Our patient earlier, Mary, for example, received radiation therapy. I'm sure you've all seen patients who get radiation therapy as either neoadjuvant therapy or adjuvant therapy after chemotherapy. Well, this is a very complex slide. These patients get exposed to radiation. All sorts of things happen. They get microvascular damage, macrovascular damage, endothelial injury, and this again hits all aspects of the cardiovascular system. To simplify this, you can really think of this as micro and macrovascular damage linked to fibrosis. This has a lot of downstream effects, including ischemia, heart failure, pericardial constriction, valvular heart disease. There are certain risk factors that put patients at increased risk. This includes a higher dose or a larger volume of exposure to radiation therapy, which is self-explanatory. Patients who are younger tend to be at higher risk because their cells are more sensitive to effects of radiation therapy. Patients who receive adjuvant chemotherapy, for example, with anthracyclines, trastuzumab, or tyrosine kinase inhibitors, are going to be at higher risk of cardiotoxicity after exposure to radiation. The type of radiation source can play a large role. Patients with either underlying cardiac disease or cardiac risk factors, this is your traditional patients, for example, with hypertension, metabolic syndrome, obesity, etc., are also going to be at higher risk of downstream cardiac side effects after being exposed to radiation therapy. So I talked a lot about cardiotoxicity. Well, how is this defined? Does my patient have cardiotoxicity? There's actually several definitions. So let's start by looking at this from the oncologic perspective. If you look at the description by the National Comprehensive Cancer Network and by the National Cancer Institute, these definitions are clinically based and relatively vague. They do have a definition from the Cardiac Review and Evaluation Committee for trastuzumab, which is a lot more concrete. So this definition is really when your ejection fraction drops by greater than 5% to less than 55% if you have clinical heart failure. If you do not have heart failure, the drop has to be greater than 10% to less than 55%. So the drop in EF has to be higher if you don't have clinical heart failure. What about the NIH? They have a series of definitions as shown in this chart. They like to grade their severity of cardiotoxicity to be a little bit more specific because a lot of this applies to trials. But essentially, they have definitions for LV dysfunction, for heart failure, and they have a definite definition for LV dysfunction that are in working trials. This can be simplified into LV dysfunction being a description that combines ejection fraction with symptoms. Again, this is graded from 1 to 5 based on severity of your LV dysfunction and severity of your symptoms. Clinical heart failure is predominantly symptom-driven, which parallels nicely with the AHA classification. In terms of clinical trials, this requires a drop in the ejection fraction from 10 to 19% to an EF of less than 50%. So this cutoff is a little bit different than the one that we described earlier. Earlier it was about 55%. The NIH likes to cut off at 50%. What about this from a cardiology perspective? So what do we use in our practice? If you look at the ACC, the American College of Cardiology, or the AHA, the American Heart Association explanation, which are the major governing societies of cardiology, they don't have strict definitions. They describe this based on the heart failure stages as well as their functional classifications. However, if you look at our imaging societies, including the American Society of Echo and the European Association of Cardiovascular Imaging, they have very discrete definitions. So they describe this as an EF drop of greater than 10% to less than 53%. So if you remember, earlier we said 55% and 50%. Now the ASC likes to use 53%, and this is really based on the mean EF and population studies. So the ejection fraction cutoff can range anywhere between 50 to 55%, and generally you want a drop in EF of greater than 10%. In terms of cardiotoxicity, we often classify this into type 1 and type 2. There's some crossover, so these are not all exclusive. Type 1 cardiotoxicity classically is defined by anthracyclines. This results in direct myocyte death and permanent injury to a myocardium. If you biopsy patients with type 1 cardiotoxicity, what you'll find is the cells are dead. You have necrosis of the cells. And we believe that this is cumulative dose related, so higher the dose, the higher the risk. Risk factors include any other cardiac history and genetic predisposition. In terms of type 2 cardiotoxicity, this typically includes our HER2 receptor antagonists, which includes trastuzumab, as well as tyrosine kinase inhibitors. This leads to myocyte dysfunction rather than death, so it's predominantly reversible. If you biopsy these patients, what you're going to find is that the cells look normal. There's minimal changes. There's no necrosis. This is not dose-related. Risk factors include concurrent exposure to anthracyclines, as well as a history of hypertension or genetic sensitivity to cardiotoxicity. So you might ask, what's the incidence of LV dysfunction? As you can see, this is highly variable depending on the type of chemotherapeutic regimen you're receiving. In general, we focus a lot on trastuzumab because a lot of our breast cancer patients receive this. And we focus a lot on doxorubicin as well as the other anthracyclines because these are commonly used in liquid cell cancers as well as breast cancer. In general, we talk a lot about doxorubicin because this is very well studied. As mentioned earlier, anthracycline has a strong dose effect. So for doxorubicin, in general, we quote a cutoff of about 400 milligrams per meter squared, given an incidence of LV dysfunction of about 5%. Once you reach 550 milligrams per meter squared, the incidence is 26%. If you reach 700 milligrams per meter squared, the incidence is almost 50%. So this increases exponentially with higher doses. But I want you to keep in mind that even though we quote these as threshold doses, this is really a continuum of risk. There isn't really a cutoff. So for example, if your patients receive 200 or 300 milligrams per meter squared, does not mean that they are safe. They are still at risk. So how do anthracyclines cause cardiotoxicity? There are a lot of different mechanisms. The number one most common mechanism is believed to be due to oxidative stress, leading to reactive oxygen species and downstream effects, which eventually cause cellular death. In addition, anthracyclines, they work by modulating topoisomerase II activity. However, we have topoisomerase II beta in the cardiomyocytes, and by modulating this, you can lead to DNA breaks and cell death. In addition, there are alterations to multi-drug resistant efflux proteins. What this does is it increases your cellular concentrations of anthracyclines, increases your cardiotoxicity. Anthracyclines also decreases your mesenchymal progenitor stem cells, and this is one of the mechanisms why we see long-term side effects from anthracyclines. So this is why, for example, our childhood survivors who get exposed to anthracyclines go on to develop cardiotoxicity in adulthood because they don't have the same amount of progenitor cells in the myocardium. So how can we modulate some of these? There's a drug known as desroxazone, which we can give patients that can decrease superoxide radicals, decreasing oxidative stress. This binds to topoisomerase II beta and can restore the normal activity. What are risk factors for anthracycline cardiotoxicity? This shows a number of different risk factors. So we know that the dose and the administration of anthracyclines can impact your risk. I'm going to talk a little bit more about this in the following slides. If you're exposed to radiation with anthracyclines, your risk is going to be higher. If you receive other cardiotoxic agents, in addition to anthracyclines, your risk is going to be higher. This includes exposure to trastuzumab, for example, or exposure to tyrosine kinase inhibitors or other potential cardiotoxic agents. If you're female compared to male, your risk is also higher. As I noted before, and a common theme is if you have any underlying cardiac disease or cardiac risk factors, your risk is also going to be higher. In terms of age, this is a U-shaped relationship. If you're at the extremes of age, either you're very young or you're very old, you're going to be at increased risk. So if you're middle-aged, you're going to be the most protected from anthracycline toxicity. So let's look a little bit about protection from cardiotoxicity. So it's a meta-analysis that looked at various ways we can protect your patients from developing cardiotoxicity when they're exposed to anthracyclines. So in this case, if you're to the right, it favors the therapy on the right here. If you're to the left, it favors the therapy to the left. So in summary of these meta-analysis, what we see is in terms of anthracycline or no anthracyclines, if you do not receive anthracyclines, you're protected. So in order to prevent your patient from getting cardiotoxicity, you should really minimize the dose. Or if you think your patient is extremely high risk, you can think about alternative regimens. If you look at bolus versus continuous infusion for your patient getting anthracyclines, continuous infusion is more protective compared to the bolus dose. And the reason is that you don't have the same peaks that you get with bolus dosing. The continuous infusion gives you lower steady state levels, as you can imagine, and because of this, continuous infusion is less toxic. We can consider giving a patient a liposomal formulation of anthracycline versus a standard formulation. So we know that liposomal formulation of the anthracycline is more protective. You might ask, why don't we give this to all our patients, since we know that this can protect your patients? The reason why we don't give this to all our patients is that this costs much more than the standard formulation. In addition, liposomal anthracyclines are associated with increased risk of hand-foot syndrome. What about cardioprotective agents? Do they work? This meta-analysis shows that if your patient receives a cardioprotective agent, their risk is lower than if they don't receive a cardioprotective agent. What do I mean by this? This includes ACE inhibitors, ARBs, and beta blockers for your high-risk patients. This also includes desroxazone, as I mentioned earlier, which protects against anthracycline cardiotoxicity. Again, you might ask, why don't we give desroxazone to all patients? Currently, it's only FDA approved in the United States for your patients with metastatic breast cancer who receive high doses of anthracyclines. There's some early data that suggested that desroxazone may mediate the efficacy of chemotherapeutic regimens, or it may increase your risk of secondary malignancies. For this reason, we don't recommend it for all patients getting anthracyclines. So let's move on and talk about trastuzumab cardiotoxicity. So how does this cause cardiotoxicity? This disrupts the signaling between the HER2 or ERBB2 and neuregulin. By doing this, it impairs your myocardial response to stress, and because of this, you're going to have mitochondrial dysfunction, and you're going to have reversible myocardial dysfunction. In addition, trastuzumab interacts with your beta adrenergic receptors because this is coupled to ERBB2, and this can also cause reversible myocardial damage. Risk factors for trastuzumab cardiotoxicity includes a history of exposure to anthracyclines, if you have abnormal underlying systolic dysfunction, or you have cardiac risk factors that includes hypertension and old age. If your BMI is higher, you're also at higher risk for trastuzumab cardiotoxicity. So this is a table that summarizes a number of different trastuzumab studies and cardiotoxicity in these studies. So we have the trial here, the time interval between the exposure to anthracyclines followed by trastuzumab, the incidence of heart failure, the incidence of LV dysfunction. So this is a clinical syndrome. This is LV dysfunction based on echocardiography. And there are two key points here. What we see is that if you get anthracycline at the same time as trastuzumab, this increases your risk of heart failure significantly. The greater the time interval between exposure to anthracyclines and trastuzumab, the lower the risk of clinical heart failure. We also see that in general, this is a reversible process. You might wonder, so my patient gets trastuzumab, we hold the trastuzumab, they get better. What do we do next? Can we give them more trastuzumab? I mean, they still have cancer, hasn't gone away. This study looked at 38 patients with HER2 positive breast cancer. All these patients received anthracyclines followed by trastuzumab. What they found is at baseline, prior to trastuzumab, the mean ejection fraction was about 60%. After exposure to trastuzumab, the EF dropped to less than 40%. Trastuzumab was held, and these patients were started on heart failure therapies, and what we find is that the ejection fraction increases back to greater than 50%, to about the 55% range. So consistent with the prior studies, the majority of these patients recovered the LV function when trastuzumab was held and they were started on heart failure therapies. What about re-challenging these patients? Can I give these patients more trastuzumab? At least in this study, when they gave their patients more trastuzumab, what they found was the ejection fraction remained mostly stable. It remained greater than 50%. So re-challenge in general appears to be safe. And this is electron microscopy of these patients based on biopsy at the end of the study. What they found is the myocytes have preserved architecture. So these are your chronomyocytes here. And essentially what we see is the cellular structure is not disrupted. This is nicely aligned for your myocytes. So as I mentioned earlier, anthracyclines puts you at risk for trastuzumab toxicity and vice versa. And the reason for this is there's significant interaction between these two agents. So anthracyclines disrupts your topoisomerase 2 beta, increases oxidative stress, and makes your cardiomyocytes vulnerable. And what happens is trastuzumab impairs the repair mechanisms, so these agents act together to increase your risk of cardiotoxicity. So this is why you want to try to space out the two therapies if possible. So in summary, we have discussed the risk of cardiovascular complications. So we know that cardiotoxicity is very common. You want to think about this for your patients who get exposed, particularly to anthracyclines and trastuzumab. Any part of the heart can be impacted by chemotherapies. I'm focused a lot on heart failure, but don't forget about the valves, your pericardium, and your coronary arteries. Cardiotoxicity is defined as a drop in the ejection fraction of greater than 10%. The threshold cutoff is anywhere between 50 to 55%, depending on which criteria you use. Anthracyclines side effects tends to be dose dependent and tends to be permanent. Conversely, trastuzumab is not dose dependent and is generally reversible. So I want to go back to Mary. So what happened with her? So if you remember, she got diagnosed with left-sided breast cancer, got lumpectomy, radiation therapy, and chemotherapy, including anthracyclines, as well as trastuzumab. Initially, she did well, but if you remember, she came back in the clinic several months later to see you, complaining of shortness of breath, and she has classic heart failure symptoms. She tells you, again, when she walks her dog, she gets short of breath, she can't go up hills, she gets tired going to a grocery store. When she sleeps at night, she wakes up short of breath. Her legs are swollen. When you see her in clinic, she has classic signs of heart failure. She has significant lower extremity edema. She has RALs on exam. Her JVP is elevated. So this confirms your suspicion that she has LV dysfunction and clinical heart failure. So I want you to now think about how often and when we should order cardiac imaging on patients like Mary, during chemotherapy, after chemotherapy. What about the role of biomarkers? Should we check troponin? What about BNP? What about other biomarkers? Is there any evidence on checking these during chemotherapy, after chemotherapy? So this is a table that summarizes our various imaging modalities and biomarkers for cardiotoxicity. Across the top here, we have our different imaging modalities, which includes echocardiography, MUGA scans, and cardiac MRI. On the right here, we have our blood biomarkers. Down the left, we have various targets in terms of which of these modalities may be superior to other modalities. So in terms of availability, echocardiography, MUGA, and biomarkers are readily available. Cardiac MRI is the least available modality. In terms of cost, echocardiography and biomarkers are the cheapest way to screen your patients. What about reproducibility? Because this is really important, right? You want to follow your patients over time. All these modalities are equally reproducible, whether you want to do echocardiography, MUGA, MRI, or follow biomarkers, which includes troponin and BNP. What about imaging resolution? In terms of temporal resolution, so this looks at the structure from a time perspective. Echo and MRI are both very effective. What about spatial resolution? So how well can you distinguish one structure compared to another? MRI is best in terms of determining this. Let's look at myocardial function. So the main focus when these patients are exposed to cardiotoxic agents is usually systolic dysfunction. So all these imaging modalities are equally effective. Echo, MUGA, MRI can all tell you your ejection fraction equally well. What about diastolic dysfunction? So this is how stiff your heart is. In this case, echo is really the best way to look for this. You might wonder, what about subclinical cardiotoxicity? So by this, what I'm talking about is before your patient has overt LV dysfunction, they might have some fibrosis, for example, in the cardiomyocytes. What's the best way to look for this? If you use echo, you can use a modality called strain imaging. I'm going to talk a little bit about this because I think this is really important for your patients. MUGA cannot detect this. MRI can look for this with either a process called T1 mapping or late gadolinium enhancement to look for fibrosis. Troponin is actually a great way to look for early cardiotoxicity before your patient has overt LV dysfunction or clinical heart failure. So let's talk a little about echocardiography. I'm sure all of you order a lot of echo. I order a lot of echo. Patients get a lot of echoes in general. So you might wonder, how do we establish ejection fraction? Is this based visually? We do look at it visually, but there's really an objective way of quantifying LV function. We often use the modified Simpson's method, which is a biplane method. So if you take your heart here, you slice your heart and take this perpendicularly, what we get is you get this 4-chamber view where your left ventricle is on the right here, your right ventricle is on the left. So what we do is we trace the borders of your left ventricle where black is a blood pool and this white is your myocardium, and we really place this along this chamber at end diastole and end systole, and based on this we can calculate the volume based on the cylinder. We also look at this perpendicularly in a 2-chamber view, and we perform the same method. So based on this, you can calculate the volumes from essentially get a volumetric assessment of ejection fraction in a very objective-based method. You might ask, for example, in these images, it's hard to see the border. So oftentimes we'll give contrast to enhance the border, and you might want to consider this in your patients if the ejection fraction is really important. So what is strain? I talked a little about strain earlier. You might start to hear more about this. So what strain is, we use the same imaging perspective where you take your heart vertically, you slice this. We take advantage of these speckles that are artifacts of echo images, essentially these low bright spots in the myocardium, and we trace this. So here, these low markers trace your endocardial borders. What we do is we take these low markers and we look at what happens to them with LV contraction, what happens to them over time from systole to diastole, and we track the movements of each of these little speckles. So this is the old location and new location. In this picture, old locations are green, the new locations are red. So we trace this for each of these speckles. And what you get is, as you can imagine, here we have an apical view. What we track is what happens to deformation of your myocardium over time for each of these speckles. And we take this in the 4-chamber view and the 2-chamber view, so the same views as earlier, as well as a more oblique view, which is a 3-chamber view. We combine these, looking at the speckle deformation, all these views, to do a calculated global strain. And the benefit of this is that if you think about ejection fraction, this is really volume-based, right? So it's how much blood really exits your heart over time. So this reflects how well your heart contracts. But your heart can really compensate. So for example, if your chamber gets larger, your ejection fraction can remain the same even if the contractility actually goes down. However, strain imaging is really independent of these changes and reflects your myocardial contractility more accurately, because this only looks at how well your myocardium deforms. So if you take the strain, combine all these parameters, what you get is a map shown here. So in this case, at baseline, strain's minus 20%. The cutoff is usually between minus 18 to minus 20% as normal. So this patient has a normal baseline strain, normal ejection fraction. And the beauty of strain, as I mentioned earlier, is that you can detect subclinical cardiotoxicity. So in this case, this is 6 months after receiving anthracyclines. So this patient's strain is now minus 17%. So it's dropped by about 15%. Our cutoff is a drop in strain of greater than 10% as the definition of cardiotoxicity. So in this case, this patient has cardiotoxicity. However, if you look at the classic ejection fraction method, this patient actually does not meet criteria. So the EF went from 61 to 55%, a drop of less than 10%. In addition, the EF remains greater than 50 or 55% depending on which criteria you use. So this patient has subclinical cardiotoxicity based on strain that you would have not detected based on standard echocardiography. You might ask, why do I care? Why should I get strain? Well, this suggests that your patient is really at high risk of downstream clinical LV dysfunction, and you might want to think about either monitoring them closer. You might want to start them on cardioprotective meds, which can include beta blockers or ACE inhibitors. In this case, for example, this patient at 12 months now goes on to develop clinical chordotoxicity. Their strain goes down further, but their EF cutoff now meets our criteria for clinical LV dysfunction. The EF has dropped greater than 10% from 61 to 49%, and this is now lower than our cutoff of either 50 or 55%. What about cardiac biomarkers? How effective are these in terms of detecting chordotoxicity? This was a study by Bonnie Kiner and colleagues at UPenn looking at breast cancer patients exposed to doxorubicin and trastuzumab, checking biomarkers every 3 months during the course of therapy. They looked at a large number of biomarkers, as shown here. These reflect a number of different things, including myocardial damage, myocardial stretch, inflammatory markers, oxidative stress markers, vascular growth markers, as well as fibrotic markers. Looking across all these markers, what they found is that troponin and myeloperoxidase, which is a marker of oxidative stress, were the most predictive of subsequent chordotoxicity. So this summarizes the effect of troponin and myeloperoxidase in predicting chordotoxicity. So here we have time on chemotherapy on the x-axis and probability of chordotoxicity on the y-axis, and what you're looking at are quintiles of these biomarkers, where blue is the highest quintile. What we see is that if you're in the highest quintile, your risk of chordotoxicity is higher for troponin as well as myeloperoxidase. In combination, these markers can be very effective. So if both of these are high, your risk of chordotoxicity is much higher than if only one of these biomarkers are elevated or if none of them are elevated. What about genetics? How does this interact with the rest of our risk factors? A number of genetic biomarkers can be very predictive. This includes drug metabolism and transport genetic changes, changes in oxidative stress markers, changes in cell survival, DNA damage and repair, as well as transcriptional regulation. I'm not going to go into this in more detail, but the point I want to make is these various genetic changes can predispose you to chordotoxicity. And this nicely illustrates how impactful this is. So what I'm showing here is a receiver operating curve. I'm sure you're all familiar with this, but essentially if you're along this line in the middle, this is the flip of a coin. So if you follow this line, it means that your variable is not predictive of your risk of chordotoxicity. If you look at clinical factors only, the area under the curve is 0.68. Usually our cutoff for what we consider a strongly predictive variable is greater than 0.70. So clinical factors can be predictive but are not great. What about genetics? If you look at single nucleotide polymorphisms or SNPs, as shown here, the area under curve is 0.81. So this is more predictive than clinical factors alone. So genetics can be highly predictive of downstream chordotoxicity. If you combine your clinical risk factors and your SNPs, this is the most predictive. So again, emphasizing the benefit of genetic profiling your patients, because this can give you added predictive ability combined with clinical variables alone. And by doing this, you can identify your patients at highest risk, so you can either monitor them more closely, treat them preventatively, or you might want to talk to oncologists about modifying the chemotherapy regimen. So in summary, in terms of imaging and biomarkers, we have a number of different imaging modalities available. I talked briefly about the benefits of each. Clinically, we tend to use a lot of echo because this is readily available. There's no radiation involved. We can use strain, which is a submodality of echocardiography, because this can detect subclinical disease and progression to overt LV dysfunction even before your patient has clinical LV dysfunction. Before they have heart failure, strain can detect early chordotoxicity, and you can try to intervene at that stage. In terms of biomarkers, troponin I and myeloperoxidase are strongly predictive of downstream chordotoxicity. We also mentioned that genetic profiling can be very important for these patients, and you might want to consider sending your patient for genetic counseling if they're exposed to high-risk chemotherapy. So going back to Mary, so if you remember, she was found to have breast cancer. She got treated. she sees you in clinic with heart failure, you decide to order an echocardiogram on her because this is readily available. Her ejection fraction is 40%, down from a baseline of 60%. So this meets our definition of cardiotoxicity. So the EF has dropped greater than 10% to lower than our threshold cutoff of less than 50 or 55%. So now I want you to think about how we should treat her and also whether this may have been preventable if we did something earlier in her case. So cardiac care is really a full spectrum, and by this, what I mean is you can consider primordial prevention. So this is when your patient's first diagnosed with breast cancer before they even receive chemotherapy. In general, you want to obtain a baseline EKG, you want to obtain a baseline EF assessment in your patients. You want to start treating comorbidities. If they have cardiac disease, you want to treat it to the optimal condition, and you will consider lifestyle modification even early on. After this, we consider primary prevention. So these are when your patients are exposed to chemotherapies. We want to follow the ejection fraction closely over time. We will consider strain imaging to detect early cardiotoxicity. We want to consider checking cardiac biomarkers, and we want to consider exercise testing in these patients to further risk stratify your patients. Because if they have limited exercise, they're going to be at higher risk of downstream cardiotoxicity. And we want to think about limiting the anthracycline dose if possible. This is really going to be on the oncologist, so you might want to talk to them about this if you're particularly worried about one patient. You want to consider cardioprotective meds with ACE inhibitors, beta blockers, and you want to consider exercise training in your patients. What about secondary prevention? So now your patient has LV dysfunction, or they have clinical heart failure and you want to treat LV systolic dysfunction. So now you want to treat them based on the standard AHA-ACC guidelines. You want to rule out other causes of heart failure. You want to make sure they're not ischemic, and you want to repeat ejection fraction after they're adequately treated. In general, at this point, you should refer your patient to cardiology or to cardio-oncology clinic. You want to consider discussing with oncology, either modifying or interrupting their cardiotoxic therapy so that you can give them time to recover before re-challenging them. You want to initiate heart failure therapies with ACE inhibitors, beta blockers, or ARBs at this point. In terms of prevention, so this table nicely summarizes our various beta blocker studies. The key point here is that there's a number of randomized clinical studies with small numbers with a variable population which have shown that beta blockers, in terms of primary prevention, so this is before they have LV dysfunction, then can decrease your risk of dropping your ejection fraction and decrease your risk of clinical heart failure. None of these studies looked at the hard endpoint or mortality in these patients. What about ACE inhibitors or ARBs? So there have been also a number of studies which have looked at these agents in terms of treating your patients. So what they found is that these drugs are also protective against LV remodeling, protective against LV dysfunction, as well as protective against changes in biomarkers. These studies have not looked at hard endpoints of heart failure or mortality. I want to discuss a few more trials a little bit more in depth because you're going to hear a lot about these since these were more recent. So there was the Overcome study in 2013, and this looked at patients with acute leukemia or malignant hemopathies being exposed to anthracyclines followed by autologous stem cell transplant. All these patients had normal ejection fraction at baseline. 80% of these patients received anthracyclines with a mean dose of 265 milligrams per meter squared. So these patients were randomized to a combination of enalapril and carvedilol versus control. What they found was that the combination of enalapril and carvedilol protected against a drop in ejection fraction compared to patients who received placebo. This protection was relatively modest. So in the control group, the drop in EF was about 3.3%. In the treatment arm, the drop in EF was 0.2%, so the change was about 3%. So there was this mild protection against drop in EF. So this was statistically significant, but is it clinically relevant? They also did look at mortality and heart failure and showed that there was a statistically significant protection from mortality or heart failure. So this combination of ACE inhibitor and beta blocker will likely protect your patients against anthracycline exposure from a primary prevention perspective. So there's a more recent PRADA study, which was published earlier this year. My wife seems to love this study. But this was a study that looked at a randomized clinical trial in Norway of 120 patients with breast cancer. These patients were exposed to a regimen of FEC, which is 5-fluorouracil, epirubicin, which is an anthracycline, as well as cyclophosphamide. About 22% of patients also received trastuzumab, 65% of patients received radiation therapy. These patients are randomized in a 2-by-2 fashion to candesartan, metoprolol or placebo. What they found is that candesartan is protective against drops in ejection fraction. Although this was a mild protection, the change was about 2% less for candesartan compared to placebo. However, metoprolol in this population did not appear to protect the patients. So the question becomes, we said candesartan is protective in this drug trial, metoprolol is not. However, is this the reality? Is this really the case? Should we not give our patients beta blockers? The thought is that this was a low-risk cohort. So these patients received epirubicin instead of doxorubicin. A lot of these patients did not receive trastuzumab, and not all patients received radiotherapy. Despite this, we saw that candesartan was protective. So if you take a higher risk cohort, so if your patient gets high-dose anthracyclines, I didn't mention this, but clinically these patients were also low risk. So if you take your patient who has a lot of cardiac risk factors, underlying cardiac disease, if a lot of your patients get trastuzumab or radiation therapy, they're likely to benefit from candesartan. What about beta blockers? In this study, this did not appear to be protective. We know that beta blockers are better at treating LV dysfunction than preventing LV dysfunction. But if you take a high-risk cohorts, you might get different results also. What about the Manticore study? You might have heard about this. This was presented at a major oncology society meeting just about a month ago. So in this case, it looked at primary prevention for patients being exposed to trastuzumab. So HER2-positive patients with early breast cancer were randomized to perindopril, an ACE inhibitor, bisoprolol, a beta blocker, or placebo. These patients received 17 cycles of trastuzumab. The majority of these patients actually did not receive anthracyclines. Their primary endpoint was a change in LV and diastolic volume index as a marker of negative LV or myocardial remodeling. What they found is in this study, there was negative remodeling or increased LV volumes in all groups. So they actually did not meet their primary endpoint. So in terms of prevention, perindopril, bisoprolol did not appear to protect against changes in LV remodeling when your patients are exposed to trastuzumab. However, their secondary endpoint were changes in ejection fraction. And what they found was that both bisoprolol and perindopril, so beta blocker and ACE inhibitor, were both protective against drops in ejection fraction compared to placebo, although these changes were modest. I think even though these changes and the protection changes were small, this is a really important study because this is a signal that from a primary prevention perspective, these drugs may protect against myocardial dysfunction when your patient's exposed to trastuzumab. What about spironolactone? So there was one study that looked at 83 women with breast cancer randomized to spironolactone versus control. This was started about 1 week prior to anthracyclines. So on the left here, we have our individual patients before and after treatment for the control group. On the right, we have our patients in the spironolactone group. What we see is in the control group, the ejection fraction dropped with exposure to anthracyclines. For patients who received spironolactone, there was no significant change in the ejection fraction. So spironolactone appeared to be protective against drops in EF. In terms of biomarkers, what they found is for patients who get spironolactone, the change in troponin was less than the change in control. Similarly, the change in NT-proBNP was less than the change in control. So spironolactone also mediated the increase in troponin and the increase in BNP compared to placebo. So at least based on a single study, spironolactone appeared to protect against drops in EF and rises in your biomarkers. However, because there has only been one study looking at this, we typically don't recommend starting these in all your patients. What about if your patient develops clinical LV dysfunction? This leaves the primary prevention paradigm and moves on to our classic heart failure framework that the HAACC has nicely outlined on this slide. So your patient now has clinical LV dysfunction, meaning stage B heart failure, or if they have overt clinical heart failure, they meet stage C heart failure. These patients should receive all our classic heart failure therapies, your ACE inhibitors, your ARBs, your beta blockers, your aldosterone antagonists, and a lot of other downstream therapies. What about timing of treatment? So this study looked at 201 patients with EF of less than 45% due to anthracyclines, and they looked at various time intervals of when enalapril and carvedilol was added to the regimen. They followed the ejection fraction every 3 months. So here on the x-axis we have time between chemotherapy and starting the beta blocker and ACE inhibitor. On the y-axis we have the percent response. So in general, if you start these agents early after treatments, so within 1 or 2 months, 64% of patients responded to treatments. If you wait until 6 months or after, none of these patients respond to treatment. So if you want your patient to respond to therapy, you really want to start these agents earlier. How does this translate clinically? If your patient responds, they're more likely to be protected from downstream cardiac events. If your patient does not respond, they were more likely to have downstream cardiac events. So earlier treatment is better because your patient's more likely going to respond from an LV dysfunction standpoint, and if they respond, they're less likely to have cardiac events downstream. So how does the American Heart Association put this together? So they have a couple of algorithms looking at pre-treatment, during treatment, and post-treatment. So before treatment, they recommend looking at your risk factors from an oncologic perspective. This includes high-dose anthracyclines, exposure to other cardiotoxic agents, as well as exposure to radiation. They recommend looking at biomarkers. This can include troponin, myeloperoxidase, or BMP. They recommend looking at baseline imaging with either echo, MRI, or MUGA. They recommend looking at cardiac risk factors, which includes any cardiac history, family history, female gender, or extremes of age, really young or really old, as I mentioned earlier. If your patient is medium or high risk, then you want to consider sending them for either a cardiology or cardio-oncology evaluation, and you want to consider risk factor modification, starting an ACE inhibitor, beta blocker, or statin at this time. You might want to consider an ischemic evaluation or consider talking to oncologists about giving desroxazone if they're going to receive high-dose anthracyclines. If your patient is low risk, then you should proceed with chemotherapy as usual. What about doing treatment? How do we monitor these patients? So they recommend monitoring biomarkers for your patients exposed to anthracyclines or trastuzumab with every cycle. In terms of imaging for trastuzumab, they recommend getting a baseline in every 3 months. For anthracyclines, you should get repeat imaging for every 50 milligrams per meter squared of chemotherapy. This is typically about every cycle once you reach a dose of greater than 240 milligrams per meter squared. If your patient receives less than 240 milligrams per meter squared, you should get baseline echo and upon completion of treatment. Also, if your patient has any signs or symptoms of heart failure, you want to repeat imaging. So if there's no change in their ejection fraction, then you want to continue chemotherapy without any changes. If they have symptomatic LV dysfunction, you should place them on neurohormonal blockade as well as diuretics and talk to the oncologist about modifying and discontinuing chemotherapy. If they have a symptomatic LV dysfunction, you also want to start them on ACE inhibitors or beta blockers and also talk to oncologists about modifying or stopping chemotherapy. What about after treatment? Do we need to worry? You do need to worry. Going back to Mary earlier, she was cured from a breast cancer, but several months later, she developed cardiotoxicity. So if your patient is low risk, for including no exposure to anthracyclines, no cardiac risk factors, no trastuzumab, then you want to repeat imaging at the end of therapy. The AHA recommends getting echo with strain. If this is unchanged, then you don't need further surveillance. So again, this is for your low risk patients. If your patient is at medium to high risk, this includes exposure to trastuzumab or tyrosine kinase inhibitors. They recommend getting a repeat echo with strain at the end of therapy. It's a little bit unclear in terms of further surveillance because there have not been any studies looking at this. In our experience, we tend to repeat an echo about every 2 years downstream. What about high-risk patients? So your patients exposed to anthracyclines or patients with cardiac risk factors. They would recommend a repeat echo at the end of therapy at 6 months, 12 months, and 18 months. So you want to repeat echoes every 6 months. And beyond that, it's a little bit unclear. In our case, we repeat echo every year after they're exposed to high-dose anthracyclines or if we think they're at high risk of developing cardiotoxicity downstream. So in summary, ACE inhibitors and ARBs, as well as beta blockers, may be useful for primary prevention. Spironolactone may also be protective for primary prevention, but this is based on a single study. For overt LV dysfunction, we recommend using guideline-directed medical therapies and talking to oncologists about modifying a chemotherapeutic regimen. For medium to high-risk patients, they need close surveillance even after treatment. So I want to end by talking about why we think there's a need for cardio-oncology as a discipline. This nicely intersects the boundaries between cardiology and oncology. So this was based on a survey by the American College of Cardiology. So they surveyed cardiologists in both academic as well as private community hospitals across the United States in terms of how comfortable they're at managing their cardio-oncology patient. So the oncology patient exposed to cardiotoxic chemotherapies. What they found is that about 39% of cardiologists were actually not that confident, and only 17% of cardiologists were very confident in managing these patients. They moved on and talked about the perceived understanding of cardiologists in terms of when these oncology patients get exposed to cardiotoxic regimens, when a cardiologist should talk to the oncologist about modifying or holding chemotherapies, when they should start heart failure therapies. Cardiologists in general actually did not have a good understanding. Their understanding was about 2.5 on a scale of 5 in terms of how well they understood when they should ask the oncologist to modify or hold chemotherapy and when they should start cardiac protective medications. On the flip side, if you look at this from an oncology perspective, in terms of how well they understood cardiotoxicity, when they should modify the regimen, when they should refer to cardiology, oncologists actually didn't do much better. They scored about 2.6 out of 5. So neither the oncologist or the oncologist alone quite understand the discipline of cardio-oncology. So this is why there has been a growing need for cardio-oncology as a discipline, which really binds these two in a collaborative environment so two teams can work together to optimize care for your oncology patient at risk for developing cardiotoxicity. And there's a clear gap in cardiovascular care. So in this study from Stanford, they looked at patients exposed to anthracyclines or trastuzumab. And here, what we see is in white, or your total cohort, blue are your symptomatic patients, red are your asymptomatic patients. What they found is for your symptomatic patients, there's still a large group that did not receive ACE inhibitors. Most patients receive beta blockers, most of them refer to cardiology. But for asymptomatic patients, despite the fact that they had LV dysfunction, a majority actually did not get ACE inhibitors, a majority did not get beta blockers, a majority did not refer to cardiology. I think there's a tendency for your cancer patient for us all to focus on cancer. And that's a very scary thing, right? I mean, if I had cancer, I would focus on my cancer also. But I want us to keep in mind that despite treating the cancer, we really also need to pay attention to other organ systems, including their heart. So the benefits of a cardio-oncology center: improves direct access by giving a single point of contact, improves communication continuity, not only for your patients, but also for the referring provider, for the oncologist, and for the primary care provider. It standardizes care. You want to take the most recent guidelines from a cardio-oncology perspective, apply this to all your patients. It can optimize cardiac imaging, assuring that your patient gets the proper modality of imaging on a consistent basis. It helps educate the patients as well as the community. And it provides research opportunities to optimize care for your patient to achieve the best outcome. So going back to Mary, she had overt LV dysfunction. We decided to hold her trastuzumab after talking to her oncologist. She started on carvedilol as well as lisinopril. 1 month later, she feels better. 3 months later, her ejection fraction returns to a normal range. She does well, lives a normal life, and as long as I've followed her, she's not had further problems from either a breast cancer perspective or a cardiology perspective. So in summary, we have defined the risk of cardiovascular complications. We have evaluated the role of imaging and biomarkers, and we have provided you with a framework for treating cardiotoxicity, not only from a treatment perspective when they have LV dysfunction or heart failure, but also in terms of primary prevention. And I've also explained the need for cardio-oncology as a discipline. Now I want to end here, and thank you very much for your attention. I'll take any questions.